Thank you very much for coming. I'm David Mills. I'm the Vice President at Kellogg, and it's a real honour to be introducing Kokila to our second talk today. Kokila, who is a fellow at Kellogg, we're really honoured that she's taken up a fellowship because I think your work is amazing around raising awareness of the issues facing paediatric surgery across the Global South. And today you're going to talk to us exactly about that, and we're really looking forward to it. Your title is The State of Children's Surgery in Global Public Health, and the floor is yours, and we look forward to a really interesting conversation.
Thank you very much. Thank you for the introduction, and we go a long way. Our children went to the same school, so we used to meet each other en route to school. And also I'm very, very taken aback that one of my trainers and colleagues is here in the audience, Keith. And also for all of you that are online, welcome. And because it's the technological era, we find more people in the virtual arena than on site. What I'm going to talk about is advocating for children's surgery in the global health arena. And all of us know that there's a lot of drive globally for HIV, TB, malaria, which are all global diseases, but so is children's surgery. And it hasn't been recognized until 2015, when the Lancet Commission did some homework and took some figures and facts and put it together and introduced surgery as a global health problem. What they did is they produced this booklet, and it shows evidence and solutions that surgery is also important in healthcare universally. The figures that came out of that at that time in 2015, we were 7 billion population, and 5 billion people out of 7 billion don't have any access to surgical care. And there are more people that die of road traffic accidents than malaria, TB, and HIV put together. And whenever I travel abroad, I'm not worried about the malaria and the HIV. I'm conscious of it, but I'm more worried about walking at night or traveling at night, because the incidence of road traffic accidents are so high. So one of the things that the Lancet Commission did is brought about a lot of figures, but I'd like to highlight this, that if the policymakers up in the world, like the World Bank and the UN and the WHO, if they do not invest in surgery, then it will cost $21 trillion in 2030 for all the disabilities that will be there and uncorrected conditions. So what we did in surgery in Oxford is we formed the Global Surgery Group because it was fashionable after the Lancet Commission for all universities to have a platform. And what we did in Oxford is that instead of having just surgeons, global health is a system. It's where you live, where you have clean water, where you have transport mediums. If you have an anesthetist going to help you put your patient to sleep, everyone matters. So in Oxford, we decided to have a plateau type of working rather than a pyramidal style where we have one leader. So we have 4 departments working together. Hilary, who leads our anesthetic department, Chris Larvey, the surgical department, Anita Makins leading the obstetrics and gynecology department, and then I do the children's sector for surgery. We also have public health workers striving towards poverty in Oxford. I mean, Oxford is a wealthy place, and in the middle of the city, there isn't much that is needy, but you just go 2 miles east, and in Beckett Lees, 9 out of 10 children are below the poverty line, and 9 of the 10 children go to school hungry, and these are statistics that Ananjani had put across just in Oxford. We also have engineers working with us that use simple techniques with hardly high-tech stuff to make a difference for children around the world. We also concentrate on undergraduates. So what we do is our medical students, we invite them to come into the global health arena, where they have what we call a special study module for 2 weeks in their year, their 4th year, and 2 weeks in their final years. And these are the people we entice. And when they come to us, we make them do a project or learn something from us and then they present their posters at a meeting, like there's one happening today, which I spoke to this morning, called Guess What, which is a trainee meeting, or we made them write essays which they can publish in their local medical journals, which gives them a pathway towards global surgery. For the undergraduates, we run a global surgery course, which we did just last week, which ended on Friday, where we have different specialities involved with surgery, talking about policy making and changing or introducing the child that needs care in the healthcare arena. So 5 billion people cannot access safe surgery when needed, but when the Lancet Commission happened, they forgot about children. And I mean, Keith can talk to that as a pediatric surgeon, that even in our hospitals, the surgeons take the resources and the pediatricians take the resources, and we fall between two stools because the surgeons push us to the pediatricians push us to the surgeons. So it's an ongoing battle in high-income countries. Can you imagine what it is in the low and middle-income countries? So in most low and middle-income countries, the population is children, and now almost 2.5 billion children don't have access to surgery. And 85% of children will require a surgical procedure by the time they are 18 years old. Be it a tooth extraction, it's still a surgical procedure. And surgery is not expensive. And we did these figures where we showed that the HIV treatment for an 11-year-old child will cost $300,000 for the child's life, whereas an inguinal hernia repair will cost $50, and that particular person is economically active for the country, and there's no disability expenses. So because the children's surgery were left out, we formed GIGS, which is Global Initiative for Children's Surgery, to embrace children's needs from around the world. And what we did is we didn't just take surgeons, we included policymakers, administrators, NGOs, surgeons, anaesthetists, nurses, to form part of this organization so we can tackle this problem in a holistic way without just being the theatre aspect of what we do. The first thing we did is we created a book of standards. So whenever we work in the health sector or in surgery, we have a standards of how surgery should be done. And this document provides standards for even NGOs who want to start up a children's NGO. There's a standard that they need to follow, which is in the document. So it's beautiful, it's easier to illustrate what I'm going to do by telling a story. So this is a condition we see in children, where toddlers will have blood in the stool when they pass. And we know there's a problem with that, where part of the bowel is kind of telescoped. And the way we treat it here is we just radiologically pump air and it's cured. In low and middle income countries, due to the lack of that, a large number, 80% of the children with this kind of condition die. And I'll show you why they die. So 8-month-old with blood in the stool in the nappy, family of 6. Mom goes to the traditional healer, which is the easiest place to go to. The traditional healer takes soap and water and put it through the bottom end to cure this and make some traditional marks. The baby gets worse because there's no healthcare in the village. The traditional healer is the healthcare. So the condition of the child worsens. So the mom absconds from the village because the villagers are saying, no, you have to go there. And she goes and reaches a medical center by walking 25 kilometers with her child because she's absconded and she's got no help. When she gets to the center, healthcare center, the baby is too ill to manage and the healthcare center can't treat this kind of condition. So there's no expertise. And the ambulance that can take the child is a day away. So she uses all her savings, takes an ambulance to go to a center where there might be treatment because the health center is directed to that treatment center. So the older 2 siblings at home stop going to school because they have to sustain the family's income. So they work on a farm and find a job because mom is gone and she can't work. So that's a loss of finances. The child reaches the tertiary center, but it's too late, right? it's too late, and now what can we do? So this is a horrific story, but the horror gets even worse because how does she get back to her village? Because the child she wanted treated has died. So mother kills herself, right? And this is just a story. There are thousands of stories like this. And now the family is in crisis because the mother absconds. There's no maternal care for the other children, and they put into deep, deep, deep poverty, right? So how can we avert these stories? So what we've done in GATES, which is the Global Initiative of Children's Surgery, we looked at the delays, right? So there are 3 delays in the system. The first delay is she didn't have local care, she needed to seek care. So that was the delay. The second delay is how did she reach care? She had to walk, there was a delay in reaching the care. And when she actually got to the care, she couldn't receive the care because the expertise was not there. So how did we tackle the first delay? We did a project in Nicaragua, which has got very difficult terrain. We trained health visitors to go on horseback to the villages to identify surgical problems and then bring them back in a cradle to a center where they can be treated. And these health workers are so dedicated. This lady just had a baby 6 weeks ago. She took a baby and the cradle where she's going to bring a child on horseback. We also found that the UNICEF in India had created a beautiful birth defects chart for their health visitors called Ashas to go from door to door while they're doing the polio vaccination to pick up children with abnormalities, birth defects. So what we did is they had a chart, and in the middle of the chart, we're putting all the surgical conditions. So one small step, we've got a whole community identifying and getting some help. So it's not the big things that matter, it's these little things that make big changes. How did we tackle the second delay? So we have a colleague who's got some funding from her home country, and in northern Ghana, she was working at a mission hospital and realized that the patients that were coming from the surrounding areas were very, very ill and almost and death's bed like the one I described. So she created mobile clinics. So she bought a Jeep and she created a mobile clinic, and with health workers from the mission hospital, they created health posts in the Ashanti region. So there are health systems within 2 hours of reach. And in each village, they trained health visitors to identify problems, which she would treat in the Jeep, like dressings or vaccinations or taking stitches out or things like that. And also train people. And she would do minor operations that can be done on the local, and then those that were ill, the Jeep worked as an ambulance, and they would then take the patient back to the mission hospital for treatment. But if it was quite severe, they would drive straight to the tertiary care hospital or the bigger teaching hospitals. And this concept has been beginning to be adopted by other countries. How did we tackle the third delay, or how we are tackling the third delay, is that when the patient gets to the district hospital, a lot of people are very scared to look after children. So we've developed a program where we've taken surgeons, anaesthetists, orthopedic surgeons, ward nurses, and theatre nurses who are adult trained, brought them to the tertiary centre to be trained in children's surgery for just basic things, so that the children's care comes closer to home rather than the delays that I talked about. And just in our first 3 pilots, we realized that it has been so effective, and the most impactful thing was the communication strand. So these surgeons or these medical teams in the district general hospital have a WhatsApp number of who to contact. Because if they have an anesthetic problem, you phone the hospital, and when you phone the hospital, it's about 20 minutes before somebody picks up. And then you get sent to 20 different departments, you get the wrong people. So this is direct access to the right person for the right advice. And we've put it all in paper and published what we've done. I've spent 22 years in Tanzania developing children's surgery. So when I came to Oxford, there was a visitor from Tanzania who was a visionary. He was the vice chancellor, and he wanted to develop specialism in his hospital. and he came looking for people to come and support them. And one of the things he wanted is for me to develop pediatric surgery. Now, I've had 2 children under 5. I have a full-time job with Oxford University. How can I do that? So I thought about it, and I self-funded myself so nobody accuses me of using hospital funds. I took my annual leave so my colleagues didn't blame me for going off to Africa. It wasn't on hospital time, it was on my own time. I took the general surgeons in the hospital and the pediatricians in the hospital to work together so that the child can be looked after by a pediatrician that had surgery, and then the surgeons have been slowly trained into doing complexity for children's surgery. Now, an adult bona fide qualified surgeon doesn't need 6 years to become a pediatric surgeon. They can learn it in a shorter space of time because they understand the principles. And now we have 6 centers, which are outlined there. We're aiming for 10, and by 2026, I think we would have captured pediatric surgery in Tanzania. We've also published educational material because all our textbooks are written by high-income individuals, and it's high-income diseases. So with us, a group of colleagues, we did the first volume, which was donated by a charity for publication, and the second one, we did it through a pediatric surgery organization, but a lot of it is online and downloadable free of charge for our colleagues. A simple study, so on an academic level, we also do simple things that are impactful. So one of the things that the mothers in the wards that were looking after the children, so in Tanzania, you can't have a child in a hospital without a family member. So the family members were saying that a lot of the children come back from theatre, and after 2 or 3 days, they're getting high temperatures, and the wounds are looking not so nice. So we did a simple project where the nurses on the ward and the doctors on the ward, we sat down together and said, let's do something simple, which is affordable. So we did what we call a randomized controlled trial. We took patients to theatre like they normally do, and then the study arm, we gave them just a bar of soap from the shop, which cost about 20p or even 1p, and a towel, and told them to wash their children thoroughly on the sites which was going to be operated on. So they have a bath, but like if they're going to do an abdominal operation, then clean the umbilicus properly. If you're going to do something in the neck, clean behind the ears and the nostrils where the infection is harbored. And we reduced infection rate by 80% with no funds, no studies, a simple thing. And it worked because it came from the people, by the people, on the ground. What I've done with medical students in Oxford is a lot of medical students in Oxford go for electives to different countries. And I told them, don't go there and do nothing. Find a partner, counterpart of yours, work with them, and I'll give you a project. And then you both work on the project, but think about why is it so different from Oxford? And because this idea was a new concept, the trainees that presented it has been a prize-winning model, because every publication that they've done or every project that they've done over the past 4 years has been a prize winner. So the first 2 years, I gave them a project, and then after that, the people on the ground in the low-income countries said, no, this is what we want to study. You came with your projects, now this is what's important to us. And that's why it's surviving, because it's coming from the ground. We also found that the patients that were coming to our hospital, the tertiary hospital, were traveling from far and wide. And we worked out that they need to get to a hospital within 2 hours. So what we realized is that the patients were getting there. The government is providing insurance, but the insurance runs out because the families then can't sustain themselves for that week that they spend in hospital. So with this publication, the government has increased the insurance for children so that when the families are looking after them, they can also be sustained. During COVID, we realized that children in low-income countries with cancers, the treatment's going to stop because it's a pandemic. All the money is going into the pandemic. We wanted to know what happened to children with cancers. So I spoke to my colleagues around the world, and within 2 weeks, we had 100 countries sign up. We have no funding, but all the medical schools were closed, all the surgical theaters were closed. So there was this massive human who were wanting to do something and were dedicated to do something important to look at what happens to children. And all these people got together, and I always feel, invest in the people around you rather than invest in or look for money. Invest in the people and the money will follow. So we did this study and we found that if you were born in the low-income countries, you had a 40-fold chance of dying with your cancer, even with the full treatment that you had, what was available, than if you came in the high-income countries. And then if you died at 1 year, the things that were responsible for the death were the income group that the patients came from, the level of, when you give anesthesia, you grade them, what is simple anesthesia and what is complex anesthesia, and also the kind of cancer that they had. And following this, we've got all the sea of these medical students and trainees picking up areas that they want to work with and picking up the leadership, so they're leading the project rather than myself. So it's succession planning and giving them, giving them the platform to grow. Also, we have in Oxford, and in fact in this country, we have junior doctors that are given academic time. So we had a junior doctor who had academic time and wanted to do something in Kenya because that's where he had some family links. And we said, okay, we've got a group of pediatricians that we work with there. We'll ask them to look at what kind of surgery is done in rural parts of Kenya. And the team came back to us and said, oh, no, that's not what we want to look at. We want to look at neonatal pain, so newborn babies and the pain that they receive. So we did the work with the local people for what they asked as surgeons, together with them. And the results that we found showed that if you can give sugar, you can do quite a lot of minor procedures with breast milk and sugar. But the concentration of sugar that we picked up in our systematic review, all the papers came from high-income countries, so they had a specific solution. And the team again said to us that, I know that's the systematic review answer, but in our society, if we're going to use that, we're going to kill all the babies because we have to titrate everything. So we changed the paradigm and used what was available locally, so it made sense. We also looked at hemoglobin, because in our countries, the threshold of hemoglobin is about 8 before we start transfusing, whereas in low and middle income countries, children run around with a hemoglobin of 6. So the transfusion level should be much lower, and we picked up 3 or 4 important pointers by making this a 4-phase study. And we realized that one of the biggest outcome of this was in low and middle income countries, people have to buy blood for their families. So people in the hospital become walking blood banks. So everyone that works in the hospital, their blood group is tested, and they are called upon to help the child with the blood transfusion if needed. So which is very telling and community spirit. Also, to end, I'd like to talk about how we save the planet, right? And as I said, the terrain is not accessible by a vehicle, as you can see. And a lot of us in the high-income countries say, okay, let's give them, you see that in the UN as well, 20 cars, let's go there, and then they can use the 4x4s to get to the terrain. How do you get to the terrain with a 4x4 atmosphere like that? So they are very sustainable for the environment rather than what we are preaching. Also in Tanzania, in the hospital, they grow their own food. So the hospital food is being grown in the gardens, and the patients that are convalescing and the parents work in the gardens to help to provide the meals. This is an invented incubator. So we have modern incubators here where we put babies in them and help them grow and keep them warm. And it cost about £50,000 for an incubator. This is a homegrown incubator which costs about £10. It's a box with a perspex glass on top. There's a shelf in the middle with a blanket, so the baby's on there and you can see the baby. There's a thermometer in the corner to tell the temperature and a heater plugged in at the bottom to keep the babies warm. £10 versus 50,000. Gloves that are used are all washed. So when theatre gloves are used and thrown into a bin, they are collected and washed so that these gloves can be used by cleaners and other people so that you don't waste. And also the parents keep the places clean. So at every point there isn't wastage, and there's using time for people. So to end, I'd like to say that in healthcare, let's work towards equity and justice. So our current situation, the reality is, it's a group of children watching a football match. And if we decide that, okay, let's resource everybody equally, the little one in the purple shirt still can't get up to see the match because he's always going to be the poorer cousin. If we say, okay, let's give equal resources, that also doesn't work because the guy with the most resources is even going to get higher. What we're working towards is give the right amount to the right people for the right purposes, and then we can have justice in healthcare. Thank you very much for your attention.
Kokila, that was a really amazing, humbling. Some of those stories just makes you think very hard about things we take for granted, and just having to sort of reassess how we think about global health and start from a different perspective.
Yeah.
It's not from a Tanzanian perspective.
Yeah.
I've got some questions, but I'm sure other people have. Commit to that conversation as much as we can. And anyone like to immediately comment or reflect? Alex.
So that was very fascinating about how you're describing how these hospitals can be sustainable and the practices that they do. I'm curious about the practice of using the plastic, reusing the plastic gloves. Is that? It's a great idea, but I wonder, is that clean?
Yeah, so that's what I'm saying, that they are rubber gloves and they get thrown away after theatre. So what the community does is they wash it, but they use it they don't use it in theatre again. It's used for, when you're cleaning the floors or when you have to pick up rubbish from the bins and put it into a bigger bin. So it's used up twice or thrice rather than for every activity you have a new glove. So that is, saving the planet by using a glove 3 or 4 times. And, you're not using it where you need clean environments. You use it for, when you're cleaning the floors and so forth.
Hello. I would like to, the timeline of the example of the mother having to travel is very powerful. I wonder, are there also community loans or charities that can just give that money for that taxi ride and also increase that accessibility to prevent that really tragic ending?
Yeah. So yes, you need to think about what is sustainable. Right? So this is one child, and then the village put the money together. They do put money together, but sometimes there are very traditional villages where the traditional healer has been very effective. So I'll just mention a few things about traditional healers. Say in South Africa, when our government changed, from the old order to a free country, the one thing we did in South Africa is we didn't take the traditional healers and throw them out. We embraced them because we knew these were powerful people in the communities that could drive healthcare in a better way. So we worked together with them where they would throw their bones to take the spirits away, which is fine. It's like you having a prayer before, looking after your ill family. So they would throw the bones, but they would also then do the right thing. So the practice of soap enema has gone down by 80% just by education. And the thing is, if you can improve the healthcare within the community, they don't need to move. And also, the WhatsApp concept has worked so well that the community nurse that's in that area knows that, okay, this child will be okay to go to a primary level, or this child is okay, will get treatment at the secondary level, or no, this baby needs to go straight to the tertiary level. So those concepts has come through. But there's a lot of community spirit. I mean, in my own education, my community put money together to put me through medical school.
Great. Yes, please, come in.
Thank you so much, Professor Lakhoo, for that amazing presentation. I have a question about the Lancet Commission that you mentioned at the start, and about how it failed to mention the plans for paediatric surgery in the scale-up up until 2030 in global surgery. Do you see this changing within the next 5 years with recognition for paediatric surgery in the realm of global surgery?
So that's why immediately after the Lancet Commission, we formed GIGS. So I was at the Lancet Commission, and in the Lancet Commission, there were 3 pediatric surgeons that didn't bring it through. And I asked them, the meeting was held in London, and at that point to say, come on guys, what are you doing? You left children out. And one of the chief person in charge of the Lancet Commission was an adult surgeon from America, said, well, if you guys are big advocates for children, why don't you go and do it? And of course we did it. We were challenged. So I had 2 colleagues that were at the Lancet Commission, and I spoke to them. I said, look, we need to have a group, but we're going to do it differently. We're not just going to say surgeons. We're going to embrace everybody looking after children. And now we've become a powerhouse. So we launched GIGS in 2016 in London, and within 7 or 8 years, we are the go-to people for children's policies. And from the projects that you see that I've mentioned, we're not talking about the problem, we're talking about the solutions.
Thank you so much.
You tell a very positive story about, an amazing story about how the commitment you've given through working for so long in Tanzania. You haven't, I wondered whether you ever feel cross about how much money goes into public health as opposed to surgery, and is that fair? Will that change?
I think that's why we have organizations like GIGS. So what we're doing now is, yes, we do see the public giving so much money for HIV, TB, which is important. Malnutrition is important, but those figures have come down. But with our involvement, the birth defects have now become the 5th common condition that the UN is going to look at. Children's cancer has risen up the ladder from the kind of development goals that people have. Surgery has become the 3rd one. So we have made movement into the policymakers, and a lot of our people from surgeons are now breaking into those realms to say surgery is important, surgery is important. So yes, we have, what I find is instead of working against the people, say let's work together and have equity. And in the same way, HIV and surgery, there's no equity there.
But also what you showed us is the value of the research, of collecting the data, because actually it speaks for itself.
Yeah.
It's a slow process that's really important. Yeah.
Slow but sure.
Absolutely, yeah, sure, definitely. Other comments? Yes, please.
I wonder whether you've been able to collaborate. Thank you. I wonder whether you've been able to collaborate at all with health economists, because one of the most telling things for me in what you said, the low-tech solutions I completely get from my experience in the HIV epidemic.
Yeah.
But one thing I wondered was, you're talking very cogently about the impact on the economic development of the country if children either are simply not there because they die unnecessarily, or if they're there but they have maybe a disability because that could have been corrected. And I wonder whether you've had any collaborations with health economics.
We do. So when I work in Tanzania, the groups are not just surgeons and nurses and anaesthetists. We work with economists and health economists. And what they've done is they helped us. What it is that health economists, and you talk about health economists. Yeah. So health economists have different language. So you will produce all your data scientifically, it's really good. But to catch the eye of the health economist in the bigger body, you need a certain language. So we have a health economist that looks at our data or represents us in the health economic language. And simply, we even work with policymakers. So we were pushing the line about birth defects. Birth defects are important to treat and manage. And in Bangladesh, we were doing a project, and we involved one of the policymakers, and we had a statement to take through to the birth defects big meeting where UN is represented. And we were saying how important the impact of surgery for birth defects, that's how a surgeon would put it. And he says, no, that's not how you should give your talk, because that was my talk. He said, the destiny of a child averted by surgery. The language.
Yes, so you get qualities and all
Yes.
those other things
Yes.
that will influence policymakers.
Yeah.
Fantastic.
And it did have an impact. It just changed the language.
And
We
as
should,
you
we
say,
should all use destiny in every papers. It's brilliant, wonderful.
sometimes it is just a case of getting the language that the people you want to listen will listen to.
You will understand.
Yeah, absolutely. Thank you very much.
No, thank you.
Yes, please.
Hi. Talking about the solutions and some other problems, we all know that since pandemic, there are lots of backlogs with pediatric surgery, including like dentals, eyes, ENT, all that. And since pandemic, not only here in the UK, all over globally as well. Are you guys doing anything in catching up with all these elective surgeries?
Okay, so I'll tell you the solution in Tanzania, right? The solution in Tanzania is they knew that the understanding was that if these children are left, it's going to get worse, and then it's going to be more expensive, you know. So say a patient with a fracture, if we don't deal with it now, this patient's going to be crippled for life. So what the Tanzanians did is they poured money into, you know, the people that have the health expertise. And every weekend, people were paid extra to cut down the backlog, right? And community hospitals were open to take teams from a tertiary hospital. I can only talk about pediatric surgery, to man those theaters. So the general surgeon will do some of the thing, and the pediatric surgeons will do some of the work, and they can get looked after locally. So that has been the way that they've done it. Here in Oxford, we have to cry for services. Anytime services are needed, it goes to adults or the bed. First thing is bed prices. So you need to do your surgery, you've got your ability, you've got your team, you've got the theatre, there's no bed. And then we don't have a practical way of working. So like in Tanzania, there's never shortage of beds because patients share beds, and you can say that's an infection risk. But you know, they put a mat in the middle, so one baby on the cot, one baby down, one baby on the platform. You would never find that in Oxford, and that's counterproductive for the crisis, you know, because we are so damned with the rules that the beds have to be spaced 2 meters apart, not thinking that the rule application is actually going to kill the child, because you've got space to put another child that you can operate on, but that's not allowed because the rule says. Yeah. And we've got too much legality.
Yes.
So there's a lot of defensive medicine. So in our institution, what we did in Oxford is that we have a district hospital called Banbury, you know, Banbury Hospital, which doesn't do children's specialized surgery. But we knew that there was space there and there was staff. So we as pediatric surgeons started taking our complexity there, because there's pediatricians are there, and they helped us look after our patients post-op with specific things that we have to look after. So in pediatric surgery, we've decreased our waiting list by working in our district general hospital, because we were so bound by rules in our tertiary center that our hands were tied. So we found a solution.
This is all sounding like self-help, and I wanted to ask you about Tanzania's history of self-help, because the first leader,
Yes.
had this philosophy Ujama, which was absolutely about the community looking after them. And you know, it was a very socialist vision, and it was a very powerful vision. He was a very charismatic leader.
Yeah.
Do you think that what you've been able to achieve, which is amazing, has been helped by that? And do you now look across at neighbouring countries like Malawi and Zambia and wonder how they're doing in comparison?
Okay. So there's a lot of drive by the community, like people like Kenneth Kaunda and Nyerere and Mr. Mandela and Samora Michel from Mozambique. They were all very powerful leaders, and they all had a socialist mindset, which was what we were fighting with. And when the system changed, Tanzania is a country where it's very peaceful. They've never had a war or a crisis. I think they had a 2-hour dispute with Uganda, and that was it, and they started shaking hands and talking together. So the question is, yes, the mindset is right, but the mindset is in other countries as well. But yes, with Tanzanians, they are very community-based, and the ethos is work with the community. The problem with Malawi is a problem that we have created in the home country. I mean, Malawi is called the Republic of Scotland. But Scotland has poured money into Malawi. It's the country that relies on aid 60% of the time. If you look at the countries around the world, the 194 countries, Malawi is totally dependent on aid. And when you speak to the Malawians that are there at present day, oh, why should we work? We get money. So the thinking is wrong. I mean, the ethos, like in South Africa, is Ubuntu. Ubuntu is working together, and if I may say a story, a true story where anthropologists from our area went to study the behavior of children in a village in rural South Africa. And he was doing kind of social experiments. So he took a bowl of fruit and he put it under a tree, and he lined up all the kids and said, right, this is the race, whoever runs the fastest and gets the fruit can have it. So it's now competition. And there were different ages of children. There were 11-year-olds and 6-year-olds and 4-year-olds. So they all kind of huddled up together because this was their challenge, and they were deciding how they're going to do this. So then he told them to stop talking and line up, and he blew the whistle, and you know what happened? All the children held hands and ran in unison to the fruit and shared the fruit. So, we are us, and that's how we can work, and that's how we have progressed. And we have so many lessons to learn from these kind of examples.
That's a very powerful story on which to end. Would anyone else like to add any final comments or questions? In which case, I think we'll probably let you go to lunch a bit early. Thank you very much, Kokila. It's been really humbling, and we're very lucky to have you in Kellogg. It's been a great talk today, and we've learned a lot. So
thank you to all, because it's people like you that give me stimulus to do more, because you're listening and you're going to take this home and do something in your area. It's power to the people.
Good.
Yeah.
Thank you. Yeah.